Mark and I will be sort of flipping back and forth throughout the presentation because we're kind of jumping between topics related to pregnancy postpartum from a mental health psychiatric lens, but also from the obstetrical lens. So it's pretty cool that we can both be here to share those different perspectives. We don't have anything to disclose for our presentation. This is the overview of what we're going to talk about over the next hour or so. To start, we're going to go through some sort of general information about the risk of perinatal transmission, so mother to fetus transmission of HIV. Then we're going to go through that psychiatric perspective, so things that we need to consider from a mental health standpoint in women who are HIV positive and pregnant. We're going to focus on issues related to adherence, risk factors for developing psychiatric illness. There are a lot of different mental health conditions that women can deal with in pregnancy, but we're going to focus on some of the more common ones. So depression and trauma will be the two that we'll take a look at. And then we're also going to talk a little bit about the mental health of HIV positive youth, meaning babies, kids who have been born via perinatal transmission and what sort of mental health issues are emerging for that population, because this is sort of a growing area of literature. And then we'll briefly sort of touch on treatment. Mark will then talk us through some of the obstetrical considerations, and then we'll go through collaborative care and talking a little bit about the P3 program at St. Mike's so that you guys can learn a little bit more about the work that's done there. So to start, just some general information about terms in the literature. There's different terms used depending on where you're looking, what source you're looking, but they all mean the same thing. So perinatal transmission, vertical transmission, mother-to-child transmission are all talking about the process of a fetus becoming infected with a virus from mom while she's pregnant. And this can occur in utero, so when the fetus is growing during pregnancy. It can also happen during birth because the baby's being exposed to bodily fluids containing the virus. Some basic numbers, and I should say, there's a whack load of references at the end, which I realize stylistically isn't ideal if you guys want to source things directly. But if you have any questions specifically about where numbers came from or which studies are being referenced, just let me know and I can pull it out for you really easily so you can follow up. So there's many women worldwide living with HIV, sort of numbers upwards of 16 million. About 1.5 million women pregnant who are HIV positive worldwide at any time. The vast majority of these women are in sub-Saharan Africa, but of course we have women who are HIV positive and becoming pregnant in the North American population. In the US, and apologies, this is US, Mark can probably tell us Canadian, but about 8,500 infants born to HIV positive moms, but perinatal infections are much lower, so less than 250. Telling us that we're actually doing something right in terms of getting these women access to care that then is helping prevent transmission to the fetus. If there's no intervention, so women who are HIV positive, HIV isn't well controlled pre-pregnancy and during pregnancy, the risk of transmission is around 25-30%. If you add breastfeeding into that, because the virus is transmitted through breast milk, numbers jump up to sort of 35-40%. So it's not like 100% guarantee that a baby will be HIV positive just because mom is HIV positive, but those are sort of numbers and odds that are generally considered unacceptable in developed countries in Canada. With intervention, rates drop down quite low to sort of 1% to 2%, and Canadian numbers dropping down to even lower than 1%, which again tells us that we are doing some of the right things in terms of being proactive and getting women access to care to get them to a state where there's viral suppression before they're pregnant. So Mark's going to take us through some more Canadian numbers.
So like Elise said, I actually have now about 5 or 6 slides that come out of this group. You can see at the bottom, it's called CPARG. Some of you may have heard of this. This is the Canadian Perinatal AIDS Research Group. So this is a group largely of pediatricians in Canada that do surveillance on HIV positive pregnancies. So they look at pregnancies to HIV positive women and those outcomes and what happens to those women and those babies. And they've been doing this for a number of years. I sit on this group as part of the SOGC stuff I do. So I have access to these cool slides. I got them to send me a couple of weeks ago, the most updated slides. So these go, if you look on the bottom, from 1990 to 2015. So these are the most updated numbers we have right now. And I think, like they always say, a picture's worth 1,000 words. So I'm just going to show you a few pictures. And I think it sets the stage a little bit of what's going on in Canada. So this first slide is mode of maternal acquisition. So how women are becoming HIV positive who are pregnant in Canada. You can see quite easily here that the largest majority of women are acquiring HIV through heterosexual contact, much smaller numbers from other ways. I always pause here on this slide, and I run the program at St. Mike's with Jay McGillivray, who's a midwife. And if any of you have met her, you'll know that she has very strong opinions about stuff. And so both of us feel that saying heterosexual contact doesn't quite always explain what's really happening. So I'll talk a little bit more about this later, but I just want to point out to you that that doesn't always mean consensual, and it doesn't always mean one act. And so we sort of feel like this heterosexual contact category maybe needs to be broken down a little bit. And I know you either have had or may have lectures on trauma. And a lot of the women, at least that we see in Toronto, who have acquired HIV through heterosexual contact, it was some sort of traumatic event, so not consensual. And I think that's important when you're looking after these women to just have that in the background of your mind. So this is showing you the numbers in Canada. So number of mother-infant pairs, this means the number of HIV-positive pregnant women in Canada. You can see that number has risen rapidly over time, and we actually love that. Most of these women in recent years are women who actively planned to get pregnant. So we're very happy that there's more HIV-positive women in Canada having babies. We want that. You can see the numbers are somewhere between 200 and 250 right now. Maternal race of the women. So the majority of women are Black. They're either African or Caribbean, of African or Caribbean descent. And then other racial ethnic backgrounds are less. You can see that sort of, I guess, the next most common are Caucasian women. Most of the women in our program in Toronto are Black women. We've looked at this. We've looked at our data many times, and approximately 80% of the women in our program are Black, either African or Caribbean women. This is showing you the distribution of the women in Canada by province. So I find this kind of interesting. So what you can see, first of all, the blue line is Ontario. So the most number of HIV-positive pregnant women in the country are here in Ontario. You can see that we're looking at approximately maybe 80 women a year right now in Ontario. In our program, we look after between 20 and 30 women a year. So we're looking after maybe somewhere between a quarter and a third of all of the women in the province just at St. Mike's. So we have, when you think of the raw numbers, 20 women doesn't sound like such a huge number, but over time that certainly adds up. And we do have a lot of experience with this, when you kind of break it down this way. The other thing I find interesting about this slide is I think a lot of people intuitively think that BC will be the next highest province in terms of numbers because of Vancouver. It's actually not. If you look over there on the side, so BC is red. So BC is the fourth. And there are more HIV-positive pregnant women right now in Saskatchewan, in Alberta, and in Quebec than in BC. Just FYI, I thought that was interesting because I think a lot of people think Vancouver is going to drive this. This one is vertical transmission rate and proportion of mothers receiving medication in pregnancy. So as you know, in 2017, most HIV-positive people are taking medications, and all pregnant women who are HIV-positive should be on medication. So the red line is total treated. So you can see it's between 90 and 100% in Canada of women who are receiving meds. I mean, I would say that every single woman who is in care, who's engaged in care, is on medication. The women who are not on medication are really, at this point, only in Canada, only women who are not engaged in care. The other thing is the black line are number infected. That means number of babies acquiring HIV. So happily, that number has gone down already quite a number of years ago to close to zero, and is very close to zero right now. And again, similar data showing perinatal transmissions. So these are babies acquiring HIV, during pregnancy, and that number is down. If you look at the numbers on the side here, we're talking about since 2000. average of somewhere between 2 and 3 or 4 a year. And again, many of these cases have very specific circumstances. I know about a lot of the cases where babies actually did acquire HIV. The vast majority of women who are actually engaged in care, probably close to 0% of them will actually have a positive baby. That's what we counsel our women. And in actually many recent studies, the percentage of babies infected in women in care was 0%. So I think we can pretty confidently tell women that if you are engaged in care, if you take your medications, the chance of your baby becoming positive is probably 0, definitely less than 1%.
So let's sort of work our way through. The first thing that I want to sort of make clear is that and this will become more obvious as Mark goes through his next section, there's a lot of different ways that we can help to reduce the risk of transmission. One of the first things we can do, and one of the most proactive things we can do, is the spacing's a bit off, but universal prenatal counseling. So getting to women before they've actually conceived so that we can make sure that they're engaged in care, they're being connected with the resources they need. That sort of helps us get going from a good place from the start. And prenatal counseling can include a lot of different things. For the HIV specific population, that includes discussing antiretroviral therapy, achieving an undetectable viral load, changing medications as needed to avoid teratogenic medications, so medications that are known to cause issues, anatomical or otherwise, for the fetus. One of the big things that I care about, of course, is counseling on illicit drug use, alcohol use, and how we can minimize or get rid of that altogether during pregnancy. And of course, one of the big things that's very important is screening for mental health symptoms, because we know that this is a population that is vulnerable to mental health related issues, HIV positive or not. And so if we can actually make diagnoses or get people engaged in care before they're even pregnant, all the better in terms of making sure they maintain a good course during pregnancy. So the question is, why do we care about that? Of course, we want people to be treated and mentally well and stable. But when it comes to HIV, there's sort of this specific cascade of things that happens. So if people have active psychiatric illness, we know very clearly it's been established that this is linked to poor adherence when it comes to taking HIV meds. If people aren't taking their medication properly, there's a risk for poor viral suppression, disease progression, not just decreased quality of life, but the potential for poor care of self. And now we've got this added element of poor care of fetus. So it does matter that we're treating active psychiatric illness, because that in itself can help a woman maintain good viral suppression or can show deterioration in her HIV status throughout pregnancy. And that puts 2 people at risk. So adherence numbers. So this is from a meta-analysis. I had an updated version actually with the specific reference at the bottom. It was done in 2012. And they looked at numbers worldwide and sort of broke the meta-analysis is actually really well done. And they broke things down looking at low income, middle income, high income countries and populations. But one of the things that stood out was that the numbers that were clear to them was that about 3/4 of women showed good antiretroviral adherence during pregnancy. Numbers dropped down to about 50% in the postpartum period. And so they looked at the literature, and again, worldwide, so looking at North America, but also sort of more developing countries. And 3 of the things that stood out as being barriers to good adherence were emotional stress, depression, and substance use. So 3 things that are definitely in like mine and Adriana's wheelhouse, and probably that some of you deal with as well. Lots of risk factors. So these risk factors come out specifically in the HIV literature, as you would imagine, with CD4 naters of less than 200. But these are actually risk factors for psychiatric illness in an HIV positive or negative population, of course. So childhood abuse, specifically sexual abuse, is well established as a risk factor. Poor social supports, and this becomes incredibly important during pregnancy and postpartum. Any history of mental illness. So if you've had a history of a depressive episode, you're then at risk for subsequent depressive episodes, as an example. And then some of the papers looked at coping styles. So if you have individuals who are more proactive in seeking out help or getting care, these are individuals who are more likely to avoid a potential psychiatric diagnosis at some point. People who have a more avoidant style are then more likely to present with mental health related symptoms. So the next few slides, we're going to focus on depression. In the work that you guys do, can you sort of come up with, like, what are some of the, if we look at DSM, what are some of the criteria that come up? What do we need to screen women for in terms of symptoms of depression? Shout out. What's part of the criteria? Oh, you don't work with DSM. Okay, yeah, it's tricky. I know the DSM is sort of, you know, the Bible in our world, but there's a lot of different ways to sort of assess for depression. But the DSM does have strict criteria, and we do use these to make accurate diagnoses. And what the DSM says is that you need to have 5 or more of this list of symptoms in a 2-week period. So it's actually quite a short period of time. The key piece is that these symptoms need to actually interfere with functioning or cause significant distress, and they can't be secondary to the influence of a drug or alcohol or a medical condition. But this is the list that we generally screen through with people. One of the 5 symptoms has to be these first 2, so depressed mood or anhedonia. Anhedonia meaning sort of general lack of interest or pleasure in daily activities or things that somebody once enjoyed. So if somebody has more than 5 of these symptoms in the same 2-week period, we can say that they meet criteria for a major depressive episode. DSM also has a specifier for peripartum onset. And I think that might have been new in DSM-4, actually. Their definition of peripartum onset, which critics say is far too strict, is onset of the major depressive episode either during pregnancy or within those first 4 weeks post-delivery. So this means that the literature becomes a little bit difficult because there's a lot of studies out there who have been more flexible with their definition of peripartum onset. So they'll say, if a woman develops a major depressive episode 6 months after delivery or even 12 months after delivery, we're still considering that peripartum onset. So it can make it a little bit tricky to sort of tease out what we're talking about when we're labeling something as peripartum onset. But that's what the DSM says. In the general population, rates of peripartum depression are 12 to 15%, quite high. A higher percentage of women deal with what we call the baby blues, right? So this transient period of time after you deliver, usually about 2 weeks, where there are a lot of emotions. So easily crying, irritable, anxious. It's mostly secondary to hormonal shifts and sleep deprivation. And that would not be considered a depressive episode with peripartum onset. This actually has to extend past the 2-week period and be accompanied by significant distress or impairment in functioning. The HIV numbers are concerning. So again, being mindful of the fact that the literature is not using a consistent definition of what peripartum onset is, but numbers coming out closer to 30 to 50%. So that tells us really clearly that these women are at high risk for dealing with depression diagnosed either during pregnancy or within the first 4 weeks or further postpartum. This is a group with unique risk factors, right? So we've got a whole list of reasons why people develop depression. We talked about some of those a few slides ago. This group is unique. So these are moms and women who are dealing with maternal guilt and fear of infecting their newborn, which I'm sure Mark sees in his practice as a reason why people are sort of hesitant to become pregnant in the first place. There's an added layer of stigma. So you've got the stigma related to mental health, you've got the stigma related to HIV, and the stigma related to potentially being an HIV positive mom who's chosen to get pregnant. And we see in this population insufficient social support. The key thing there in the women who I've treated is that they haven't wanted to disclose their status to people in their life. So they actually have somewhat of a social network, generally speaking, but when they're pregnant, they're fearful of disclosing the HIV status. And so they really function through a lot of this alone if they don't have healthcare providers who are there for them. The other big thing that comes up in a lot of different studies is that a diagnosis of HIV while you're pregnant is actually one of the strongest risk factors for developing depression. And in Canada, I think it's every province, it's sort of universal HIV screening unless a woman opts out. And so it's an opportunity where people who may not have thought that they had ever been exposed may be dealing with a diagnosis. And that's an added risk factor that we need to be mindful of. So here's the piece that's really interesting that you brought up. And this was a study done at USC by a group there who, it was a retrospective chart review, but they looked at about 300 women who had delivered, HIV positive women who had delivered from, I think it was 1995 to 2007. And they looked specifically at rates of peripartum onset depression and CD4 counts, and found this sort of really clear trend that women who had CD4 counts of less than 200 were 3 times more likely to experience depression with peripartum onset versus moms who had better control of the illness and CD4 counts over 500. And, you know, that study was done 2012. There's been sort of very little done since then, but it opened up this sort of interesting question of this bidirectional relationship. Is the depression causing non-adherence and that's causing CD4 counts to drop? Or is the HIV not under good control? That's causing sort of physical symptoms that then manifest as depressive symptoms. It's a bit of the chicken or the egg, and I don't think we know. So I think the thing that is the silver lining here is that we're starting to ask these questions, and these are questions that probably matter a lot in terms of finding answers that help these women maintain good viral suppression, good CD4 counts, so that they're not at risk for transmission and they're not at risk for mental health issues related to the HIV. I think that that's a part of the problem in teasing out the numbers, is that the definition of peripartum is so inconsistent. And somebody who's using a 4-week cutoff versus a 12-month cutoff, you're going to get wildly different information. So I think that that's really interesting, and I think it's part of the issue in the literature. It needs to be teased out a lot more cleanly. So we're just going to shift over to PTSD. Again, we're not going to go through all of the criteria, but the DSM-5 says that there are sort of 5 main categories of symptoms in PTSD. So the first is that somebody has to have had an exposure to a trauma. This can include actually witnessing a trauma. So seeing something very traumatic happen to somebody else can be considered a trauma in itself. The second cluster is intrusion symptoms. So this is where things like nightmares, flashbacks, intrusive memories come in. Avoidance symptoms. So this is avoiding things that remind you of the trauma. So if it's a assault, avoiding that area of the city, avoiding people who look like the person who assaulted you, that kind of thing. Negative alterations in mood and cognition. There's a lot of overlap with depression, actually. So irritability comes out, persistent low mood comes out as symptoms here, and alterations in arousal. So people will often describe sort of this hypervigilance, always being very mindful and aware of who's in the room and where the exits are and that kind of thing, and also being sort of easily startled. So this is DSM as per, or PTSD as per DSM-5. The literature is actually limited in PTSD. There are some studies out there that have looked at PTSD and pregnancy in a non-HIV positive population. There's not a lot that's focused specifically on the HIV positive population, but there's a lot of overlap between these two groups. So if we look at sort of trauma in general, we know that the majority of traumatic events for women are sexual assaults. So from the get-go, we know that if we're dealing with a traumatized female population, we're dealing with people who have a high chance of, in some ways, having had their bodies invaded against their will at some point. So one might assume that, pregnancy, the process of a vaginal delivery, can be re-traumatizing in some ways. And some of the things that come up are that you're out of control of your body. Even though it's a natural process, vaginal delivery, it's still a process that you're not necessarily in full control of. When you feel contraction, when the baby is ready to come, all of those things. There's also fear related to sort of the degree of decision making. So how much control will I have in the room? We know from working with traumatized populations that lack of control is a very worrisome thing because they've had, these very scary things happen to them where they had no control. So that also stands out as a risk factor related to pregnancy, surviving childbirth, and also having healthcare providers who at the early stages are strangers to you, conducting things like pelvic exams, where again, they're sort of close to these very private personal parts of your body. So it makes sense logically that pregnancy and delivery could be a re-triggering experience for women who have dealt with sexual trauma. Some things to sort of keep in mind clinically. There's a possibility that you can see worsening of PTSD symptoms specifically in the month or 2 months leading up to delivery. And this is because they're really being activated in terms of retriggering, because they're noticing major changes in their body and they're fearful of delivery. And Mark can probably speak to that sort of from a clinical standpoint, that you see that anxiety heighten when they get close to delivery. Re-traumatization can also happen in pregnancy. So interpersonal violence or domestic violence can be common in a pregnant population. So always making sure that we're screening for IPV or for domestic violence. And then making sure that we are always focused and implementing trauma-informed care, which we'll talk a little bit more about in treatment. So from there, I just want to spend a couple of slides, and I'm just mindful of time, but I just want to spend a couple of slides talking about that, the sort of child and adolescent population, kids who have been born HIV positive via perinatal transmission. So just to sort of consider, again, specific risk factors in this group. And some of these, you could argue, aren't different for kids who are dealing with other types of chronic illness, right? So early involvement in medical care, hospitalizations that can lead to missing out on certain life experiences, not going on the school trip, not being able to date or be part of certain clubs or whatever because you're having to be at the hospital, be with doctors. The physical experience of having an illness at a young age, dealing with pain, dealing with bodily sensations that the average kid might not have to deal with. Stigma linked to dealing with a chronic illness at a young age. And one of the big things that stands out, and this is not HIV specific, but is illness and the early death of a parent. So the experience itself of growing up with a mom or a dad who is ill, is at the doctors themselves, is in hospitalizations themselves, or who dies at a young age, that in itself is a risk factor for psychiatric illness down the road, regardless of HIV status. And if we just sort of look a little bit at the biological sort of continuum, so, and again, we don't know a lot about this, but some of the studies talk about, changes to subcortical white matter, changes to frontostriatal regions of the brain. These are areas of the brain where there's anatomy that is specifically important to a regulation of emotion and executive function. When we say executive function, we mean the ability to plan, organize, multitask, things that we actually need as we're growing up to help us regulate ourselves and our behavior. If we don't have that, we have poor impulse control, we have disinhibited behavior, which most teenagers have anyway. But if you have this added sort of biological insult, you can see those behaviors sort of exaggerated. And then that puts them at risk for getting involved in substance use and risky sexual behavior. And it doesn't really allow these kids to learn how to regulate themselves. So as you would expect, we see some trends in the literature. So we see higher rates of things like ADHD, which is an illness that comes with a lot of symptoms of executive dysfunction, right? These are individuals who can't plan, they forget, they can't organize. We see higher rates of anxiety disorders, and we see behavioral disorders. So things like impulse control disorders, conduct disorders, things that sort of demonstrate that people are having a difficult time regulating themselves. So this is just sort of highlighting that there are protective factors, and I think it's a population that we actually need to do a better job at targeting, because we can change their trajectory effectively if we get to them young enough. That's all I'll say about that, though. So let's just talk really briefly about treatment. When we're dealing with treatment and a pregnant population, it is always a risk-benefit discussion. So there's pros and cons to being on a medication during pregnancy, and there's pros and cons to being off of a medication during pregnancy, if we're talking specifically about psychiatric meds. Always our goal is non-pharmacological, so these are things that are usually pretty benign to implement and usually help reduce the chance of somebody dealing with depression, for example, during pregnancy. So boosting social support, protected sleep time, particularly in that postpartum period, home visits, so getting public health nurses involved, and psychotherapy. So there's good evidence in the pregnant and postpartum population for cognitive behavioral therapy, and specifically for interpersonal therapy. One of the focus areas of IPT is rural transitions, and becoming a mom is a big rural transition. So that can be a very effective therapy if you can get access to it for the postpartum population. We always want to be thinking about trauma-informed care. And this can mean a lot of different things. And this list is certainly not comprehensive. But it's a way of approaching patient care where we're giving them some sense of, we're not just giving them a sense of, we are giving them control over their decision-making, control over some of the treatment plans. We're making sure that we're doing a good job about creating a safe clinical space for them, where they know all of the team members, where strangers who are medical students aren't wandering in the room and doing a pelvic exam or something. We're trying to mitigate that imbalance that can sometimes exist between healthcare providers and clients or patients. And it's specifically important to mitigate and minimize that imbalance in the traumatized population because they are very sensitive to a difference in power or a difference in control. And the last thing I'll talk about really briefly is just sort of a quick review of antidepressants, SSRIs, which are the most common form of treatment for depression and PTSD. And just very, very briefly, these are the 6. Now there's a 7th, 40-oxetine, that's on the list. Some of them come off of the list pretty quickly when you're talking about treating a pregnant female, specifically a pregnant female who is on antiretrovirals. So fluvoxamine has a lot of drug-drug interactions, specifically with some of the protease inhibitors. We just don't use it a lot as an antidepressant anymore. Paroxetine actually stands out in the pregnancy literature as being potentially linked to cardiac malformations. The data is a little messy, and there are people out there who would argue otherwise, but it's enough that if you can avoid Paxil and go with a different SSRI, most providers would do that. And fluoxetine, again, has a number of drug-drug interactions, specifically with some of the antiretrovirals. We just avoid it. These bottom 3 are usually my go-to medications. Sertraline specifically is the safest in breastfeeding. And the message that I think is just, I want to be clear on, is that there are safe pharmacological treatment options if you have clients or patients who are in need of a medication to help them with their symptoms. Not everybody needs it, not everybody wants it, but there are safe choices out there.
So this next section is actually quite a bit of a shift. And I put in a bunch of slides on what we actually think about when we're looking after an HIV positive pregnant woman. So it's not so much mental health focused. I know this is a mental health series, but I put them in because I wasn't sure exactly who the audience would be. And I wasn't sure if you might find it interesting to hear about something you might not know that much about. So I may go through them a little bit more quickly, but just to kind of give you a flavor of some of the issues that we think about from the more, medical standpoint of looking after positive women. So this first slide is really just one more graph to show you HIV testing in pregnancy. So as Elise mentioned, HIV screening is recommended for every pregnant woman right now. This is relatively universal across most developed nations. Canada's nothing special. This is a slide that's old now, but looking at testing in Ontario. So you can see in the late 90s, testing rates in Ontario were quite poor. They were around 40 to 50%. And a huge push occurred from public health to try to increase this and improve this. And it worked. And so now the graph basically stays the same. Like this ends in 2011, but if you extended this out to today, it's the same. I mean, we're in the neighborhood of the upper 90% of testing for pregnant women in Ontario and in Canada and in North America. So a little bit about what to do if you're looking after an HIV positive pregnant woman. So first of all, I think it's really important to be humble. I think that none of us can do this alone. And in most probably areas of medicine, we work in teams and groups. And this is a good example. You need a lot of people from different perspectives to really, I think, appropriately service the needs of an HIV positive pregnant woman. The prenatal care provider is certainly not all that you need. There's a lot of other partners, and this is just a few. There's a lot of other people and groups that I can think of, and I'll mention some of them specifically when I talk about our program in particular. So these are some things that we think about. First of all, testing in pregnancy. How often or regularly should you look at CD4 counts and viral loads? I think that it's pretty individualized. In many women now that we see, they are women who are known to be positive, who have been on medications for quite some time. This is not a new thing for them. But pregnancy can be tough. If any of you have been pregnant or know any pregnant women, you will know that it's not so easy sometimes to be pregnant. It's hard to take medications. And so even in women who are well controlled and stable, we still do want to monitor their blood counts because sometimes things change. And so if women are stable with undetectable viral loads, I usually say once a trimester, do a viral load. You certainly could do it more often often, but if you look at the literature, sometimes it will say do it monthly. Most of us think that's probably not necessary. What is really important is to do one near the end of pregnancy. We want to have a viral load sometime around delivery. So in our practice, we usually do it about a month before the due date, just to confirm that we are still dealing with someone who has an undetectable viral load, because that's really important in terms of transmission. In terms of genetic screening, so all pregnant women are offered the options of genetic screening, and this is the same for HIV positive women. There's no big difference here. They're offered serologic or blood screening with tests that are called IPS or MSS. These are tests that look at pregnancy hormones and give a risk for how likely it is that this baby might have genetic problems like Down syndrome. For a long time, people who had positive tests would then be offered an amniocentesis, where you put a needle in and take fluid out. We were quite cautious about doing this in HIV positive women because putting a needle through the uterus can cause bleeding. And if there's blood mixing, maybe that increases the risk of transmission. We think now with undetectable viral loads that risk is probably extremely low. And so you can consider amnios for positive women. The really good news is that in recent years, very recently, new testing has come out. Some of you might have heard of this, called non-invasive prenatal testing, or NIPT. That's actually a blood test that is almost as accurate as an amniocentesis. So for most of our positive women, we don't do amnios anymore. I mean, I would say for most women in general, our amnios in our prenatal clinic have plummeted because most women get NIPTs. Ultrasound, this is one thing where I would say there is relatively big differences between HIV negative and positive women. So everyone gets the same routine ultrasounds, but there's been lots of data that has suggested that HIV positive pregnant women may have, or maybe at increased risk, I guess I could say, for early labor, preterm labor, and also for babies that are smaller. And we think that this might have to do with the way the placenta is working in positive women. We don't really know why. There's theories out there that it's probably related to the medications more than the HIV itself. But because we know this, we usually do more ultrasounds in this population. We want to look and make sure the babies are growing normally, that the amniotic fluid volume around the baby is normal. These are all signs of the placenta working well. And so these are things that we check. In a pregnancy in a woman who has no big complications or problems and is HIV negative, the anatomy ultrasound is the last recommended ultrasound in terms of our national Canadian guidelines. A lot of women have another one after that, but it's not officially recommended. In HIV positive women, we always do another one, at least one, and sometimes more, depending on what we find. So this is what I tell women at their first visit with me. You know, one of the big differences between you and someone who's HIV negative is you're going to have more ultrasounds. Most women don't mind that because they like to see the baby, so it's usually not a hard sell. In terms of medications, we already mentioned this, that, you know, in 2017, certainly most HIV positive people are going to be on medication, and the same goes for pregnant women. We've said for a long time that all pregnant women should be on active regimens because we want them to have an undetectable viral load. And we would like it to be undetectable for as much of the pregnancy as possible. So, you know, a few years ago, we used to see women who came to us in pregnancy that were not on medications because they didn't officially qualify for medications when they weren't pregnant because their counts were so good. We don't see that very much anymore because now most HIV positive people are started on meds right away. But if you have a pregnant woman not already on medication, we would definitely start her. We usually traditionally did not start them in the first trimester just because we don't like to give any drugs in the first trimester if possible. There's very little evidence that almost any of these drugs are concerning in the first trimester, so you could give them. The other practical point about the first trimester is it's when a lot of women don't feel good. So it is challenging sometimes to take medications in the first trimester. So suffice to say that they should all be on medication as early in the pregnancy as possible. That, I think, would be my summary message for that. This is one data slide I wanted to put in here. This is a very old study, but probably the most important study in HIV and pregnancy. So some of you might have heard of this study. This was the study that showed that if you put women on medication in pregnancy, you could decrease the chance of their baby acquiring HIV. So this study, if you look at the bottom, this was published in 1994. So it's very important to remember that this study was done in the early 90s. That was a very different era for HIV. So we didn't have viral load testing back then. We don't know what these women's viral loads were. And we were talking about an era where there really were very few medication choices. It's a very different time. But what they did back then was they took women with HIV and randomized them to either get drugs or get placebo. And the drug was AZT. It was the only drug that was available back then. and it was monotherapy. We never do that now. So this is very different from current era. But it's interesting that even knowing all of that, the results were very dramatic. So women either got this drug regimen, and if they got the drugs, what happened is they got AZT when they were pregnant, orally. They got AZT in labor through an intravenous, and then the baby got AZT syrup for 6 weeks after birth. So that was the drug arm, and the other arm was placebo. They got nothing. And so what you can see if you look here, in the placebo line on the graph, the rate of transmission was 25%. And Elise mentioned this, and I think it's important to pause here for a second. Remember that even if you do absolutely nothing, if you have a woman who you don't even know she's positive, or you do know and she doesn't get treated, the risk of transmission is only 25%. 75% of the time, the baby will still be negative. So I find that interesting. If they got AZT, just the one drug, the rate went from 25% down to 8%. So quite a dramatic decrease. It decreased by about 2/3 just with one drug. And that was not even given throughout the entire pregnancy. Some of these women didn't start till quite late. Nowadays, we know that if women are on highly active regimens, as I mentioned earlier, the risk of transmission is less than 1%. So we've been able to take this and even improve it further. But I still like showing this study because this is actually the study that we still base treatment decisions on in pregnancy. This is why we give women medication in pregnancy, because of this study, which is now more than 20 years old. Okay, just a few other things. The actual drug choice usually is made by the HIV provider, not by me. I believe that all positive pregnant women should have an HIV provider because I'm only going to see them in pregnancy. I'm not going to see them forever and ever. Most women nowadays have a protease inhibitor as part of their regimen, so they're on what we call highly active regimens or combination therapy. We're seeing a lot more integrase inhibitors used in recent years. That's, some of you probably know this, the newest class of drugs, and even more probably active than protease inhibitors in terms of getting the viral load down quickly. In pregnancy, integrase inhibitors are used a lot in women who come to care late. So they show up at 32 weeks or 34 weeks, untreated or never had access to care, and have viral loads that we want to get down quickly. An integrase inhibitor-based regimen can bring their viral loads down to undetectable very, very fast. And for us, that's important because we want them to be undetectable by the time they go into labor. So again, as I mentioned before, side effects are hard, with some of these medications, even harder, I would say, in pregnancy when someone already might not feel so great. So you have to work carefully with women who are either on meds or starting meds in terms of adherence and coaching them, in terms of getting through those side effects. Yeah, we're seeing less side effects. And I think just in general, like over time, right, in the past 10 years, in the past 20 years, there's less and less side effects with newer regimens, which is great in general and for sure in pregnancy. So I think we have a lot less problems now. When I was a fellow training, I won't tell you what year that was, but it was a little while ago. And some of these regimens were not available, and we used to have a lot of problems with adherence in pregnancy. It's hard to remember to take meds at the best of times. It's hard to take medications when you're pregnant at the best of times. To try to take regimens, and in those days, some of those regimens were multiple times a day regimens. When you're pregnant and you're big and you don't feel good and your stomach gets full quickly and it's hard to take them with food and all of the restrictions, it was really tough. So I think we're in an era now in pregnancy where I don't want to be flippant about this, but I will say to you guys that I often say when I'm talking about HIV in pregnancy, the medical care of HIV in pregnancy is not so complicated anymore compared to what it used to be. We put people on medications, they get an undetectable viral load, they do great. But there's a lot of other issues in this population in pregnancy, which is why I think we're giving this talk together. And I'm going to mention a few of those issues at the very end. So I told you that study for the AZT study, one of the arms was AZT in labor. So I put this slide in to tell you that in Canada, we still do recommend IV AZT in labor for all women. In the United States, if any of you know this, they have taken that recommendation out. They've said that if someone has an undetectable viral load, they probably don't really need the AZT in labor anymore. And that may actually be true. But in Canada, we've decided to keep that recommendation there for consistency and so that people don't have to try to decide on an individual basis who needs it and who doesn't. We think there's no risk to using it in labor and potential benefit. You'll see my last point. As part of our program, we've learned a lot of things. And one is that privacy and confidentiality is probably almost the most important thing to pregnant women. The very most important thing is they want a negative baby. The next most important thing, which is just a millimeter underneath, is maintaining their privacy and confidentiality. We have a lot of women like what you described, who no one in their life knows they're positive. And that may be okay in their general lives, but when they get pregnant, that can sometimes be a lot more challenging. There's a lot of people that come into their lives when they're pregnant. Their family gets a lot more up in their business when they're pregnant, and especially once the baby's born. And so it can be much more difficult to maintain that confidentiality and privacy. And then remember, they're coming into the hospital to have a baby where they're meeting like tens or hundreds of people. There's all sorts of people from all sorts of different services interacting with them, and it can be very challenging sometimes to maintain this. So we work very hard at St. Mike's, where I work, on this. One of the many things we've learned is that when you have AZT, it runs on a pump. You can't have that label visible because family members poke around at everything in the room. So if you have a pump running and it says AZT, most people actually know what that is. So we cover the labels on all our pumps. We actually worked with pharmacy because initially we wanted the pump not to be labeled at all, but that's not actually safe. So it's labeled, but it's covered. Just a quick word on how long you can have ruptured membranes or the water broken. So again, old data showed that if the water was broken for a long time, it increased the likelihood of transmission. This makes sense, right? Because the membranes protect the baby. Once the membranes are ruptured, then virus or bacteria can easily spread into the uterus. So there were some good studies that showed that if the membranes were ruptured for a long time, transmission increased. But again, these were in that same era as the AZT study, when we didn't know viral loads, when people were on one drug. So we don't really think this applies to the current era. And we did a study here in Toronto a few years ago at St. Mike's at Mount Sinai. We had over 200 women that we looked at in the study. And you can see here the viral loads were undetectable in 80% of them and less than 1,000 in all of them. So, even those that were detectable were very low. And we had no transmissions, and it didn't depend how long the membranes were ruptured. And there's been other studies since then that have showed the same thing. So we think in women who are undetectable, this rule doesn't really apply. We've been able to be a lot more liberal with our care in many ways with women who are undetectable. Lastly, mode of delivery. So again, I sound like a broken record. Old data showed that C-sections decreased your risk of transmission compared to vaginal birth. This was back in the day with, poor drug regimens and higher viral loads. Currently, we say that if someone's viral load is under 1,000, then it's safe to have a vaginal birth. So they don't necessarily even have to be undetectable, although that's what we want. But even under 1,000, we would allow them to have a vaginal delivery with the thinking that that's not going to increase their risk of transmission. I just want to briefly talk to you about the model that we have developed at St. Mike's. And so I think Elise put this slide in so we could just remind you again about the need for collaborative and integrated care when you're looking after HIV positive women. From whatever perspective. I look after HIV positive women who are pregnant and from a gynecologic perspective, but even in my gynecology population where they are not pregnant, we certainly involve a lot of ancillary services to, help with a variety of different things. I want to tell you before I get to these slides that I said this before, in our positive pregnancy program, 80% of the women are of African or Caribbean descent. I would say that well over half of those women are refugees. So they're people that have come from some sort of a traumatic background and often have come directly from that background directly into care with us. They sometimes arrive pregnant. And so this is sort of one of the reasons why I say the medical care is not so complicated compared to everything else, because these women may have a lot of other issues relating to the social determinants of health. And we see that not just in pregnancy, of course, but in the gynecology population too. So I think that you need to have good partners when looking after this population in order to really adequately help them. So our program is called the Positive Pregnancy Program. And we didn't plan it this way, but we realized after that meant there were 3 Ps. And so we call it P3. The reason I think that's cool is because on our labor floor and postpartum floor, when we are talking about a particular patient, as we do about all sorts of, patients on the floor, we don't say, oh, in that room is an HIV positive woman. We say in that room is a P3 woman. And the reason why I like that is because if someone happened to be walking by, I mean, we shouldn't be doing this in the hallway, but if we are doing it in a less secure spot, we don't say the words HIV. So, a family member or some random person in the hallway isn't going to hear that, oh, that person's HIV positive. So it's another sort of way to protect confidentiality. Most people in the general public don't know what this P3 means, so they wouldn't know what we were talking about. So as you've heard, it's a collaborative model. And I think most unique feature about it is that Jay and I started this program together. We started it over 10 years ago. It's quite unusual in the prenatal care world for an obstetrician and a midwife to be equal partners / friends / work well together. It doesn't always happen that way. And so we're really proud of that. And we like to hold this up as a model to say, you can have cross-disciplinary models that work well if you have the right people working together. But I also want to say that in our program, it's Jay and I, and we have a prenatal nurse, Kathy Beatty, and a social worker who has changed a couple of times. But the four of us really are the core team. So we are the ones who see all the women when they come into the clinic, all four of us almost at every visit. And we have access to a whole host of other services across the city and beyond in terms of things that some of these women may need. So as I mentioned, a lot of them are new to Canada and may have very little in the way of resources. So we link to a lot of these other organizations. We want to normalize care. We want these women to feel like they're just like every other pregnant woman, and they really are. And we should behave that way. And so these are some of our partners. Some of you will have maybe worked in some of these places or know these people. So you can see that we link to a lot of other medical clinics, including psychiatry, including pediatrics, because there is a baby involved here, and including fertility clinics, because some of our clients come from fertility centers. We link with pharmacy, obviously very important. And we link to many different community organizations, legal organizations, housing organizations, and some of the really good community services in Toronto. We work very closely with some of the women-based services, especially Women's Health and Women's Hands and the Teresa Group. We could not run our program without these services. And we actually, I'm proud to say, involved these services from the very beginning in terms of helping us structure the program to make sure we were adequately addressing the needs of the population. And so basically it's a weekly clinic. I run my prenatal clinics on Mondays. My prenatal clinics have all HIV positive and negative women coming on the same day. The HIV positive women do not come at a special day and time. They told us that's how they wanted it. They didn't want everyone to know that Monday morning was HIV morning, so that if you showed up Monday, you had HIV. They wanted to help maintain anonymity. And so everyone comes on the same day. Nobody knows who's who. Jay never goes to the waiting room to call patients, because what happens is that I see all the women all day. Jay only sees the positive women. And so if Jay goes to call someone, then everyone would know that that woman was positive. So, again, small things that we've learned over time to help maintain that confidentiality. And we do sort of formal and informal discussions around each case and formulate care plans. The nice thing about the two models of care is that I'm an obstetrician, so I work in a group of OBs. So we have a call schedule, so I'm not there all the time. Jay is a midwife, and midwives actually attend the births of all their clients. So we can tell the women that there is probably a greater than 90% chance that Jay will be there unless she's away. And that really, I think, is reassuring to a lot of these women who are more vulnerable. So it's collaborative, it's team approached. We hope that we're patient and family centered. And the really cool thing also about this model is that I see all the women, Jay sees only the positive women. So Jay has a lot of time to spend with these women. So all of these issues that we've talked about, that Elise has brought up, many of these issues occur in this population. And Jay's sort of the first point of contact to delve into some of that. And you can imagine, over the course of a pregnancy, when you're coming possibly 10 times to see people, you really do eventually, we hope, build a bond. And a lot of these women disclose a lot of their past histories and things that they've gone through. And I also think that when you're dealing with sexual and reproductive health care, it brings these things up to the surface. And this is why we closely link to psychiatry and social work, because a lot of times these issues come up. And this is a good time, if this woman wants to try to address some of this. We do have broad demographics. So I said that a large proportion were African and Caribbean, but you can see here that, and a lot of these overlap with each other, but we have women from all sorts of backgrounds. I will say that in our program, we call it the Positive Pregnancy Program, but we also look after women who are particularly at risk. So maybe at risk for HIV and maybe marginalized, but not HIV positive. So sometimes we see women who are unstably housed or living on the street that may be in the sex trade or that are involved in drug use, and they may not be positive women, but they are women at risk and they fall into our program as well. That's a picture that I love. That's a picture of Jay right after a birth. This woman has given consent for this picture to be used with her face blurred out. But I think this captures the heart of the program because I think Jay is the heart of the program. The question, I'll repeat the question in case people can't hear. The question was about women who don't have status, so who don't have any kind of insurance or ability to pay. So I wouldn't say that our program particularly has funding for that, but our hospital does. So we have ways also to try to access funding for women like that. We've seen a lot of women who don't have official or formal coverage. So if you have someone like that that you would like to send to us, feel free to do that because we can usually work that out. We've been very successful actually, and I should give credit to some of our community partners because certainly some of the community partners that we work with have also helped us to cover the costs for those women. Excellent question. So, the question about infant feeding, this is a passion project of many of ours these days. So let me answer. The short answer is that currently in resource-rich countries like Canada and the United States, it's recommended that HIV positive women do not breastfeed and that they use formula feeding. We're very lucky in Ontario. The Teresa Group, which is a community organization, supplies formula free for a year for any HIV positive woman who has a baby. So these women don't have to pay for it, and the formula is shipped to their closest pharmacy. So it's a very good program that takes convenience and cost out of the equation. Having said that, it's very challenging for some of these women to be told not to breastfeed. In our society, where breastfeeding is considered the gold standard, and there's a lot of media attention and a lot of pressure to breastfeed from internally and from friends and family and the community, it's really hard for these women to accept not breastfeeding. The other thing is that the World Health Organization guidelines state that if you are living in a resource-poorer area of the world and you're HIV positive, it is recommended to breastfeed exclusively. And so the challenging thing for a lot of the women in our program is they are coming from those areas and they may have had babies already in those areas, been told to breastfeed, breastfed, their baby's negative, then they move to Toronto, and now we say it's your third baby, you breastfed number 1 and number 2, but we are telling you should not and can't breastfeed. And for many years, for all of us working in this field, this was a no-brainer. We just said, don't breastfeed. That was it. It was done. And we've realized over the past few years that it's not so easy and that it's really not easy for these women. And we actually organized a community forum on this a few years ago, and it was a terrible rainy day. I thought nobody would come. It was on a Saturday or a Sunday, and about 60 or 70 women showed up from the community to talk about this. And so we've forged this infant feeding working group that's active across Ontario, because I do think that, I think we're probably going to learn, and we are learning, that it's probably okay for women who are undetectable to breastfeed. I think we can't say that yet in a guideline, and we can't say that yet with 100% confidence, but I guess that's a long answer, and let me summarize by saying that we are open-minded to speaking about it. And one of the things we talk about with every single woman during the pregnancy is what are your plans for infant feeding? Because it's a big, big issue. But the official recommendation currently is still no breastfeeding. I think, the question was about termination. I think it was something we saw more of in the past. And unfortunately, when I first started at St. Mike's, I was hearing stories of women who were told you should, if you're pregnant, you have HIV. I don't know about this. And, I don't really see that I don't see it very much anymore. I guess that doesn't mean it's not happening. But maybe the better answer to your question is I certainly have had some women in my practice, even in recent years, who have had that experience. Even if that experience was some time ago. And the decision to terminate a pregnancy simply because they were HIV positive really did have quite significant repercussions from a mental health standpoint. These were women that had a lot of regret because they weren't terminating for, there's lots of reasons why one may choose to terminate a pregnancy. This was sort of a reason that I think it wasn't really coming from them in a sense. And they absolutely had issues because of that. Thankfully, I don't see that very much anymore. I don't know if you do. I don't see it much. What I see now is all of these couples who are trying to get pregnant. I mean, I do tons of visits, pre-pregnancy visits, where people come in to see me because they want to get pregnant. And they're trying to, like you asked, they're looking for information about how to do it, where to go to do it. So it's skyrocketed, actually, which is amazing. And we see, now that we've been running this program for such a long time, we have what I like to call repeat customers, lots of repeat customers, lots of women coming in for their second baby, their third baby, satisfied, hopefully. But yeah, lots of women who now I've seen them have 3 babies, and it's amazing. It's really amazing. Resistance from the woman, you mean? Yes. Yes, absolutely. Okay, sure. Yes. And women who are very educated about this, they have done the research, they know the guidelines, and they question it. And I think rightfully so. They say, how can you tell me that I'm the same person in the same body? 6 months ago, I lived in, wherever the country was, usually somewhere in Africa, and I had breastfed my baby. Now I've picked up and moved here, same person, same medication, same undetectable viral load. Now you're telling me I can't breastfeed. What are you talking about? It's a great question. And so, the thing that I learned from this community forum and that I have learned since is that some women are breastfeeding. And so I think in my mind, what's most important is it's a choice, right? Everyone makes their own choices. And so I think what's important is that we have to provide women with the information, tell them what the guidelines are, tell them what the literature is that we know, and then you decide. But if someone is going to breastfeed, then I think I would much rather know that they're doing it, to make sure that they're sort of at least following as many rules as possible to stay as safe as possible, versus, telling us they're not doing it, but yet doing it and run into some sort of problem. And I think that's what a lot of us working with positive women feel now. We want to keep the dialogue open. I'd much rather know what's happening. And I do think it's people's choices to make. And from a mental health perspective, so important because, there's so much pressure on women. Yes. And for a lot of these women, if you do not breastfeed, then you're basically saying, well, people think, well, there's obviously something going on here. Are you HIV positive? And so there's an incredible amount of pressure